Good morning, everyone.
Yeah.
Today I'll be presenting my work that was done at Narayan Nethralaya. No financial disclosures. With over 101 million diabetics in India, I think diabetic retinopathy is a condition that we are very aware of, and we need to prevent vision loss in these patients, for which we need something more definitive as a treatment. And how do we find that? Well, recently vitreous sampling has shown us that we are able to find out biomarkers that can actually help us predict the disease and also choose a treatment option that is more suitable for our patients. But vitreous sampling is invasive. We need to take the patients into an OR to do the same. And in our armamentarium, we have other ocular fluids such as tear samples, we have aqueous, and we also have blood, which is so easily accessible because we commonly use it to test our diabetics. So which is why we came up with this bright idea of comparing these biomarkers across these 4 ocular fluids, that is the VAST study. And we wanted to look whether these biomarkers across these 4 samples correlate, and if they do, how strongly do they correlate. So that's our VAST study for you. We included 22 patients who were undergoing vitrectomy for complications of PDR. We collected all 4 fluids in these patients and we tested them for different processes. So this is in brief how the study was conducted and how we looked at the correlation of these soluble factors. At our in-house grow lab, these fluids were stored, they were segregated and then sampled for 53 soluble factors. We used different quantifiers because one single method was not suitable for all of these factors. Finally, the absolute concentration for each of these was then quantified. Now, as expected, plasma had the highest protein concentration, and we used something called as a normalization method to make all these samples comparable. The principal component analysis, as you can see on the right here, shows that the ocular fluids all cluster together. So that makes organ specific sampling very important. Whereas down below you see that the plasma ones are quite separate from the ocular fluids. Now this is something called as hierarchical clustering. This becomes important because if you see now in cluster 2, several of these inflammatory and angiogenic factors are clustered together. That means that these factors are closely associated across the different sample size. That again becomes very important. So now out of the 53 samples, we saw that 48 of them were significant, and the highest correlation was seen between vitreous and aqueous, and 28% of them correlated across all the 4 samples. Now this is something called as a Sankey plot. This basically demonstrates the complex interplay between the soluble factors and the sample source, and the red arrows actually indicate clinical significance or potential drug targets, which are now listed here. Now besides the usual VEGF and the angiopoietin, you can also see a whole lot of other inflammatory markers. Well, we did have certain challenges. It was difficult collecting 4 samples across different pathologies, and also there was a lot of systemic variability, that can affect the outcomes of our study. However, the repeatability made it more easier for us to be able to predict therapeutic targets and also enable us to patient-specific prognostication. So this is the first study where we were able to compare 4 samples, and we hope also that this is the first step to finding novel, customized, targeted treatment for our patients. We saw the strongest correlation between vitreous and the easy to acquire aqueous, and tears also gave us some hope with less invasive surrogate sampling. Organ specific sampling, like I mentioned before, seems to have more clinical relevance, and I think eventually we will be able to find samples besides the invasive vitreous sampling. Now let me illustrate with one case here. This is a patient with DME who underwent anti-VEGF treatment. You can see that the response is not very great. On aqueous sampling, we found that the VEGF levels were quite negligible, but the inflammatory biomarkers are much higher, as you can see. Intuitively, we switched this patient to steroids, and you can see that the response was fantastic. Imagine if you could have done this much before. Now let's see this lady. She's a 56-year-old female who came with decreased vision of 5 months. She had NPDR with DME, and this was her biomarker profile. You can see that the inflammatory biomarkers are much higher than VEGF, and we gave her a steroid, and look at the response. It's fantastic. Imagine if even before the injection, if we could predict that this was going to be her outcome using steroids, and that too with something as simple as a tear sample or a drop of blood, the patient would have been extremely relieved with more targeted treatment. So friends, the future is bright. We are on the brink of bespoke or personalized ophthalmology with a promising non-invasive biomarker. which can be repetitive and which can be not only used to monitor disease but also personalized therapy. Thank you so much.
And this paper was Colonel Rangachari Award winner. Congratulations. Any way you can correlate other confounding factors like patients having high risk characteristics? You found that these inflammatory markers or VEGF or angiopoietin was raised in those patients, or patients without high risk characteristics. Any comparative study like that?
In this particular study, we didn't compare it across different diseases, sir. So this was only PDR. And all patients with PDR with either a tractional retinal detachment or a VH were taken. Inflammatory conditions such as uveitis, even anterior uveitis were ruled out. None of these patients had any existing inflammation at the time of the surgery. So whatever markers we are seeing are specific to the disease. We also ruled out any other systemic illnesses other than diabetics or hypertension, because we know that hypertension cannot cause that much a change in these biomarkers. So we restricted it to these kind of patients only. That's why we had a sample size of only 22. But now we've included other disease spectrum as well, and we're going forward to see how the inflammatory biomarkers actually change with respect to other systemic issues as well.
And maybe like the inflammatory markers were more, initially you give steroids, and later on as the disease progresses you find angiopoietin or VEGF increasing, then you can switch over to other.
That's maybe the entire intention of trying to reduce the injection burden on the patients.
Exactly.
So when we target it at the first go itself, maybe repetitive injections are not required.
It's very significant paper.
Yes.
Thank you.
Thank you, sir.